Hi, everybody. This is Dr. OG from MP Skills Made Easy Workshops, and you're listening to the Prescriber Essentials podcast, the show that helps you delve into the world of clinical skills and knowledge for clinicians who love to continually improve their clinical skills. I discuss content to help you grow professionally and the opportunities and strategies to provide excellent care like a pro. But I'm just going to start off by talking about obesity as a chronic disease. So a couple of things that you want to know as an advanced practice provider is that obesity is actually a chronic disease and is linked to several health conditions like your type 2 diabetes, your non-alcoholic fatty liver disease, pulmonary and cardiovascular disease. So again, essentially your metabolic syndrome typically would be related to obesity. So moving forward, we're just going to talk about your semaglutide and liraglutide effects. So again, semaglutide, which is Wegovy, and liraglutide, which is Saxenda, they both induce weight loss by lowering energy intake. Semaglutide does reduce your calorie intake by about 35% compared to your liraglutide. So again, another good thing about semaglutide that you want to know would be that it does help reduce food cravings. So some of your patients will come in and they tell you that, okay, well, yeah, they're able to get through the mornings without, snacking or, eating fast foods or what have you. But after that 4 p.m. slump, it's almost like, okay, well, I really need to eat something. So again, semaglutide would definitely help with the food cravings. But again, your job would be to say, okay, well, there's some healthy food options, snacks that might also be helpful for the food cravings. But again, it's just good for you to know. And then, of course, Zepbound, which is tirzepatide, that's a GLP-1 receptor agonist, is another option for the patients that, maybe their insurance may not want to approve your Wegovy. See if they can approve the Zepbound. So that's another alternative for these patients. So I'm just going to talk in general about your medication side effects. So again, this would be specific to your semaglutide and your liraglutide. So GI side effects like your nausea, vomiting, gastroparesis. Some patients would actually complain that they feel so full that they don't want to eat anymore. But remember that this is part of the mechanism of the action of the medication. So again, nausea, vomiting does occur in about 84% of patients who take semaglutide. And, again, very similar, 83% of patients that take your Saxenda, liraglutide, would complain about some GI side effects. So again, how to mitigate this is really to start at a very slower or lower dose. So again, making sure that you're not quickly increasing that dose, because once you get to the max dose, most of your patients would definitely have that GI side effects. It's also important to prepare these patients for this possible side effects before starting treatment, and just letting them know that this is the GI side effects is real, and they would feel a little nauseous, and they can have some vomiting, they can have that feeling of fullness. In practice, we actually had some patients that had to go to the ER because they were diagnosed with gastroparesis related to the GLP-1s. So that's something that you definitely want to keep in mind, and not increasing that dose very quickly would help you to stabilize the patient. So these are some some studies that showed some weight loss with semaglutide. So again, weekly semaglutide injections with diet and exercise. And of course, the patients would typically have more weight loss at 68 weeks than your daily liraglutide. So semaglutide definitely is a better medication, pharmacotherapeutic for weight loss. But again, it depends, because some patients' insurance may not cover, and you may want to, try out the liraglutide and see how the patients do with that, of course, and if their insurance will cover that. And then, of course, this research studies show that the semaglutide does benefit. It demonstrates the benefit of once weekly dosing combined with lifestyle changes. I couldn't tell you how many patients in the clinic that I've seen that they come in, they just want a refill of a medication, and you're talking about lifestyle changes, and they really are not wanting to exercise, they're really not wanting to eat better. Again, it's your job to make sure that you're really telling this patient and setting expectations that, yeah, the medication alone is not going to help you lose weight. You still need to exercise, you still need to diet, you need to watch, do your own part, and then the medication would just enhance what you're already doing. All right, I'm going to switch gears and talk about pharmacotherapeutics and some options that you have there. So remember that, like I said earlier, the GLP-1s are pretty expensive. Most of your patients' insurance, they would want for you to start, try something else before approving the GLP-1s. So medication approved for adult obesity would include semaglutide. We talked about that already. The tirzepatide, your liraglutide. Orlistat is another one that you can try with this patient, and we'll talk about that more detail. Phentermine is another one. Again, remember, phentermine is a Schedule 4 drug, so again, you always have to keep that in mind. It does cause some palpitations in some patients. You want to also keep that in mind. And then, of course, your Contrave, which is your naltrexone, bupropion combination. So each medication has a different mechanism of action, and we'll talk about that, the dosing and the side effects profiles. You want to become real familiar with this as well. So we're going to start out with the semaglutide Wegovy. So remember, we talked about it. That is a once weekly sub-Q injection. So the patients would have to get the shots once a week. The mechanism of action of semaglutide is that it does increase glucose-dependent insulin secretion. It slows gastric emptying and lowers glucagon secretion. So again, the patients, your ideal patients will be patients 12 years and older. You do not want to give it to any pediatric patients that is younger than 12. And so the FDA approved Wegovy for patients with a BMI that is greater than 30 or 27, greater than 27 if they have at least one comorbidity. So again, that could be hypertension or diabetes or thyroid disorder. Again, remember that 27 would be for patients that have some comorbid conditions, and BMI 30 is approved for everyone else. So again, the dose for Wegovy typically would be you starting at 1.25 milligram. Again, like I said, you want to stay at the lowest dose, as much as possible. I've seen patients in the clinic that come in and they want for you to, within a week or 2 weeks, they're like, okay, well, can you increase the dose? So you want to be real careful to tell the patient that increasing that dose to 2.4 very rapidly could increase the risk of the GI side effects we talked about, including gastroparesis. Another thing that you want to think about, some information that you may want to provide on patient education would be, of course, having this patient eat some meals. So again, meals should be eaten at least 30 to 60 minutes before, the dose. Sorry, not before, after the dosing to reduce the risk of nausea, vomiting. So again, remember that nausea, vomiting is something that you want to discuss with the patients. What about some patients with pancreatitis or the risk of pancreatitis? You want to make sure that you're not prescribing semaglutide to this patient. This is really important as nurse practitioners or physician assistants that we know this information. Patients that drink alcohol, maybe substance, abuse alcohol, that could be at a risk for pancreatitis. Be real careful with Wegovy. And then, of course, patients that could have or at a risk for thyroid C-cell tumors. Again, this is a black box warning by FDA showing that this patient would not do very well with this medication as well. So again, it's contraindicated. You do not want to actually prescribe semaglutide, Wegovy in patients with thyroid C-cell tumors. All right, I'm going to move forward and let's talk a little bit about your tirzepatide, which is your Zepbound. So tirzepatide works like semaglutide. How it works is really to increase insulin secretion. It slows gastric emptying. So if you remember that I talked about the side effects, including gastroparesis, and that is really the mechanism of action of this medication. Your ideal patients will be patients 12 and older. And again, this would be the dose. 2.5 is what you really want to start the patient out with. You can increase to 10 milligram and 15 milligram. Be real careful again to quickly dial up to that 15 milligram because of the side effects. Tirzepatide, which is Z-bound, it's approved for similar BMI and age criteria. So we talked about 30, greater than 30 BMI in most of your patients and greater than 27 in patients with any type of comorbid conditions. And then, of course, very similar to your Wegovy, the GI disturbances are also common. Remember that patients with thyroid C-cell tumors or who may be at risk should really not get any of the GLP-1s. All right, we're going to talk a little bit about your liraglutide, which is Saxenda. So again, the mechanism of action of liraglutide is to increase insulin secretion. It slows gastric emptying, and it does decrease inappropriate glucagon secretion. Again, your ideal patient will be patients 12 years and older, and you're titrating this weekly dose every 7 days. Okay. So we're starting at 0.6 milligram, and then of course we can get up to 1.8 milligram. The GI disturbance is also something that you want to talk about with these patients, and patients should eat a meal about 30 to 60 minutes after the medication. All right, so let's talk a little bit about Orlistat, which is Xenical. So Xenical, it works a little different. It does inhibit the gastric and pancreatic lipase, and it also blocks the absorption of dietary fats. Orlistat should be used in patients, should be prescribed in patients who are 12 and older. It should be taken at least 3 times daily with fatty meals, starting at 120 milligram dose. So again, the BMI of 30 or 27 with one comorbid condition is another criteria for starting a patient on Xenical. And side effects that you definitely want to keep in mind and you want to talk about this with your patients will be flatulence and oily spotting. Again, just remember the way that it works, right? It does block the absorption of dietary fats, and that's why most patients will see that oily spotting with bowel movements. So again, you want to keep that in mind. We'll talk a little bit about your Adipex, phentermine, and phentermine topiramate, so QCMI, however you want to say that. So remember that phentermine suppresses the patient's appetite through the CNS, right? It has to be going through that CNS effect. We typically will prescribe phentermine in patients who are 16 and older. So again, it has to be patients that are a little older. It's a schedule for a controlled substance, so you want to be sure that you also have your DEA license before prescribing phentermine. And then Adipex doses, so again, phentermine doses range from 15 to 37.5 milligram daily. And then, of course, the combo, which is phentermine topiramate with the QCMI, the dose range from 3.75 to about 15 milligram. So the way that you want to kind of think about this would be that patients are coming and you're prescribing phentermine topiramate. It does work in 2 ways. It combines appetite suppression with other mechanisms of action. Remember that phentermine does suppress appetite through that CNS system. And then, of course, the topiramate also works in combination with phentermine really to suppress this patient's appetite. So again, it's something that you want to know. And it's dosed weekly as well. We're going to talk about Contrave. So that would be your naltrexone and bupropion combination. The mechanism of action of Contrave is really to combine, and it does block opioid receptors to reduce appetite and cravings. Of course, you're starting at the lowest dose, and then you're going to titrate this over 2 weeks. So 90 milligram / 8 milligram. Remember, this is a combination medication. And then, of course, you want to increase that by 1 tablet a day until 2 tablets every 2 weeks. So in my practice, most patients that talk about craving quite a bit, they do very well with Contrave. This is something that you want to keep in mind, especially if they cannot afford the GLP-1s. So again, Contrave is an option for your patients. Be aware that Contrave is not suitable for patients with severe liver impairment or patients who have a seizure risk. So again, keep in mind that these patients would not be good candidates for Contrave. All right, so let's switch gears a little bit and talk a little bit about your newer generation obesity medications. We did touch upon some of those, but we have some newer GLP-1s and newer medications that are in the horizon that you definitely want to know about. So again, semaglutide, we talked about that. It does produce about 15 to 20% of weight loss in most of your patients. Tirzepatide, 15 milligram would produce about 15% of weight loss in most of your patients. Retatrutide is a newer obesity medication. It does produce about 24% of weight loss in most of your patients. And of course, your survodutide does produce about 18.7%, so about 19% of weight loss in most of your patients. So these medications, they target multiple pathways involved in obesity. And so that's why, it's good that we kind of know what's, in the horizon, the ones that are already here and the ones that are making their way to the market, that you become familiar with those as well. If you like what you hear on this show, then be sure to check out our Prescriber Essentials Academy, which is a continuing education platform where we delve deeper. Visit schools.mpskillsmadeeasy.com to join us. See you on the other side.